So what I'm going to talk about today is occupational therapy and what occupational therapy is, what kinds of things we do as occupational therapists, because a lot of people are not familiar with occupational therapy, or they might have had some occupational therapy in a different setting, but it can be very different depending on where you're at and what you're doing. Okay, so we're going to talk about that, and you can ask me any questions at the end. So what is occupational therapy? And when I say OT, that's going to be my abbreviation for occupational therapists. It's difficult to keep saying it all the time. So when I say OT, that's what I mean. So OTs help people across the lifespan participate in the things they want and need to do through the therapeutic use of everyday activities. I know that's kind of a long definition, but basically what that definition sums up is that we treat people from children, actually newborns, to people in their 90s and 100s, as long as someone might live, and we help them do the things that they need to do in their daily life. So occupations, though, what is an occupation? So occupations, someone might say, wait, I don't need occupational therapy, I already have a job, or I'm retired. A lot of people think when we say occupational therapy that we're going to be working on work. But that's not actually what we mean by occupation. An occupation is anything that you need to be able to do in your daily routine. So there's many different definitions out there in the literature. But what it basically breaks down to is an occupation is anything that is meaningful and purposeful, anything that you need to do, you need to do, or you have to do in your daily routine. And it is unique to each individual. And it's going to provide you with that satisfaction and fulfillment in life. So who are OTs? As an OT practitioner, you must have completed an accredited master's program. There is a doctorate program now also for occupational therapy, but you don't have to have that yet. That's more for if you're doing research or teaching. But you have to get your master's degree, and then you have to pass the National Board for Certification in Occupational Therapy. It's just like any other board to become a healthcare professional. And where do we work? Well, we work in tons of different settings, and that's why I say you might have seen an occupational therapist before or know somebody who has, but it's different per setting. So we work in hospitals, inpatient rehab units, outpatient rehab units like here, schools, home health, skilled nursing facilities. So many different places, and that's not even it. There's many more, but those are the main areas. So now that we kind of know the broad aspect of what an occupation is, I'm going to break it down for you because there are so many different things that people have to be able to do or want to do or need to do. So the first part that we mainly address are this page. So we look at somebody's activities of daily living. And that's short for ADLs. So if you hear me say ADLs, that's activities of daily living. ADLs are things like bathing, dressing, combing your hair, brushing your teeth, all of those really basic things that you need to be able to do. Instrumental activities of daily living are short for IADLs. So IADLs are those activities that most people do in their daily life, but maybe don't have to do. So shopping, managing your medications, cooking, cleaning, all the different things that most people do. Rest and sleep are occupations. We don't let you come to therapy and just sleep. That's not training. You don't get to come take naps, but we do talk about it and address it and make sure that you're getting proper amounts of sleep or that we can make modifications to make it easier to sleep. Education, so some people who are in school might need occupational therapy. Work, if you're still working, you might need occupational therapy. Play is considered what you do for fun. That kind of coincides with leisure. As a child, you have to be able to play. That's how you learn, right? So with children, you work on if they're able to play. And then leisure is what you need to do for fun. What's going to keep your brain hopping? And then social participation, because we now know how important social participation is for your brain. So we make sure that you're able to achieve those things. So here's a slide of the activities of daily living. So washing, feeding, dressing, toileting, transferring, that's getting in and out of bed, in and out of the shower, in and out of your car maybe. and mobility, which is mainly the focus of physical therapy. So we do work in conjunction with physical therapists to achieve those mobility goals that you might have. Here's the list of the instrumental activities of daily living that I kind of covered. So it's very broad, and I covered some of these already, but caring for others. So if you are a caregiver, or if you're helping your mom and dad or your children, caring for your pets, being able to feed them, being able to walk them, being able to clean up after them, child rearing, taking care of your children, communication management. Communication management might be, can you use your phone okay? Can you use your personal assistive devices? Can you use your communication boards? Driving and community mobility, financial management, health management, so that's getting enough exercise, making sure your diet's proper. Home establishment and management, so that's where the cooking and cleaning and fixing things, all those things you need to do to maintain your home come into play. Meal preparation and cleanup, religious and spiritual activities. If you have to go to a church and be able to get into a pew and kneel down, that's a lot of tasks right there. Safety and emergency maintenance, and shopping. So this is just a slide. It's kind of confusing, but I put it up here because it shows you how many things kind of play into yourself. All these things that we look at. It's a very broad spectrum, and so we kind of look at a bunch of different things, and this is kind of how we function off of this. This is our domain. It's how we work, what we look at in the person when they come in, which I'm going to talk about in a minute, but I like this slide because it really shows all the different parts and how they play together. And then the OT process, and then we're going to delve into that too. The OT process is how we achieve these things. What do we do with you when you come to see us? So that's what we're going to talk about next. So evaluation. An evaluation is an assessment. If you come to see an occupational therapist, these are the things that we look at. So first, we determine what the person needs and wants to do. We identify the factors that are supporting or hindering that performance. So we do that in a multitude of ways. First, we get the occupational profile. The occupational profile, we get a lot from interviewing the person. We talk about your history, what kinds of patterns of daily living you're doing. We talk about your interests and your values and what you need in your daily life. So we talk about why you're coming to see us, what reason you came, why you're seeking the service, what your strengths are, what your concerns are in relation to your occupations, and what are your goals. That is the main thing. Occupational therapy is very goal-oriented. We are very holistic, and we look at the person as a whole. We want to know what your goal is and what's important to you. And then we do an analysis of your performance. So that might include a lot of different things, but we basically are interviewing you, we're observing you doing different things, and we're doing assessments that are evidence-based. So we're looking at different things, comparing them to how other people have done on those assessments, and seeing what problems you might be having that might be impacting your performance. Intervention. So after we did the assessment and the evaluation, we get to intervention. Intervention is a long word for treatment. That's basically, so treatment is what we're going to do with you. So first we develop a plan, and that's what will the treatment consist of. So we think about your goals, we think about what approaches to therapy that we might use, which I'll talk about in a second, and then we look at the evidence behind the treatments that we want to use. Are they going to work? Are they going to work for your diagnosis? Are they going to work for all the different factors that are playing into your life? And then we do the implementation. The implementation is the process of treating. So what types of interventions, and we're going to talk about all the types of interventions we might do with you, and how long. So how long might a treatment go on for? The treatments here are 60 minutes long, 55 to 60 minutes, and we typically see people 1 to 3 times a week. In this population, mostly 1 to 2 times a week, but there are places where you will go 3 times a week. And you reassess after every month and determine if you're meeting those goals, or if you need to keep coming back, or if you've met your goals and you can be discharged. And that's kind of what the review is. The review, we're looking at how you're doing every 30 days and determining what your needs are. Do we need to change up some of your goals because you met them and you're wanting to work towards something else? Or do we need to focus on a different method of getting to those goals? So these are the treatment approaches that I was just talking about. So the different ways that we approach the treatment of occupational therapy is that we're aiming to kind of do one of these different areas. So we're either aiming to create or promote some kind of ability. So this is an example, a fall prevention class to encourage safe mobility throughout the home. So you're creating safety in people that don't really maybe have a problem yet. Establishing and restoring. Establishing and restoring is what we do oftentimes. So establishing and restoring, an example would be if you're going to restore upper extremity range of motion, so that's how high you can reach your hand up, so that you can safely transfer dishes from the dishwasher to your overhead cabinets. So we're restoring that motion you might have lost for some reason. Maintaining. So maintaining is actually something that we're focused more on nowadays than we used to, because we've been showing, the insurance companies that it is necessary in some populations. So maintaining might be keeping something where you want it to be, because some people can't quite get better, but you don't want them to get worse. So that would be a maintenance program. So you might maintain somebody's range of motion to manage their spasticity, so that a caregiver might help more with bathing and dressing. So for example, somebody who has a lot of tightness in their arm, you might help teach them how to keep that where it is so it doesn't get worse, because if it gets worse, the caregiver's not going to be able to help clean them properly. Modifying. So modifying is changing something up to make it more efficient and make it work better. So an example of modification would be to simplify a task so that somebody who's cognitively impaired can complete a grooming routine. Sometimes people have trouble sequencing things, so you have to figure out a way to simplify that. So you're just modifying it, you're doing it in a different way. And then preventing. Preventing isn't something we do so much here, but there are OTs out there that do that. So preventing, an example would be an OT might consult with a hotel chain to provide an ergonomics, which is how you use your body, program to prevent back injuries in their housekeepers. So you're consulting, teaching people ways to not get hurt. That's what preventing is. Okay, so here's the fun part. These are types of interventions, and that's kind of what my main focus is today. So what do we do? So we'd use occupations, as we discussed what that is already, and activities. So some examples of ways that we do this are maybe we might help somebody, teach them how to complete their morning dressing and hygiene routine using adaptive devices. So I have a bunch of adaptive devices here today, and we'll take a look at those. We might teach or help somebody learn how to purchase groceries and prepare a meal. We might practice safe ways of getting in and out of a tub and make modifications to make it safer and make it better for them. We might help somebody develop a weekly schedule so that they're better able to manage their time and responsibilities so they can maintain their independence. Because a lot of times cognition can't necessarily be fixed, but there are ways that you can work with that to make yourself more independent. Somebody might want to be able to play a game. That way they can engage in leisure and social activities. So we might work on them with how to make that happen so that they can maintain that social aspect of their lives. Okay, so then we also might use preparatory methods and tasks. Preparatory methods are ways of preparing yourself to do something, or trying to achieve something by doing something else. So we might have somebody folding towels and as the means to increase their range of motion. So instead of just giving them stretches and exercises all the time, we might have them folding towels to work on that technique that we're trying to get from them. It's just more, our body responds really well to functional activities. It definitely needs exercise, but sometimes it likes whenever we change things up. We might have somebody participate in a sensory environment to help promote alertness. So this is very important in populations where people have lost a lot of their cognitive ability and they need some stimulation. So we teach them how to use their senses to calm their body or stimulate their body. So they might be aromatherapy or calming music or meditation or different methods to help stimulate your senses. We might perform a home-based exercise program with the patient and help them develop something to increase their strength and balance. Just like physical therapy, they're always working on balance and strength in the legs. So sometimes we do address balance and the upper body strength as well. And then we might make recommendations to somebody to use adaptive equipment to be able to feed themselves. Okay, so let's take a look at some of these equipments really quick. I just brought some things. There's a ton more out there. Occupational therapists are experts at adapting things. We adapt things all the time to help people figure out what they need to do. So we have a sock aid here today. This helps people be able to put a sock on if they can't reach their feet. It also helps them be able to put a sock on if maybe they can reach their feet, but it just takes so much effort and it makes them too tired. So this is a really good contraption for that. Works really well too. We have a shoehorn. So a lot of you have probably seen a shoehorn, or you might use a shoehorn, but it basically helps you get your shoe on without having to bend over and use as much effort if you can't. We have a leg lifter, so this is good for people who can't get their legs into bed on their own. If you have good upper body strength, then this is a great tool for you. You just hook this end on your foot and you can help lift your foot up into bed or into the tub if you can't get your foot over the tub rail. This is a reacher. You guys have definitely probably seen one of these or know somebody who has one, or you might have one yourself, or 10. You might have one in every room. It basically helps you pick things up if you've dropped them. And maybe you don't have good balance and it's not safe for you to reach over and grab something. Or maybe you had a hip replacement and you can't bend over to put your pants on. So there's a lot of different uses that you can use this for. Okay, and then we'll get to the rest of that in a second. We do a lot of education and training. So we might do education regarding home and activity modification. Again, I said occupational therapists, we're good at modifying things. So we are good at modifying the home or making recommendations to make your home safer. We might instruct somebody in how to do self-range of motion on themselves so that they don't lose that range of motion. Range of motion, again, is how far you can move your joints. Are they able to move in all the ways they need to move? So we might teach somebody how to maintain that by stretching. We might instruct somebody in how to use a handheld electronic device and use the applications on it to manage their weekly activities, to remember to take medications, to communicate with other people. There are lots of different things that you can use a device for. And we might instruct somebody or direct them how to tell their personal care attendant or their caregiver what their needs are or how to help them best. Because sometimes you might have to have caregivers to help take care of you. And you should be able to instruct them in your needs and how to best care for you, because that's part of your living. We also advocate. So some OTs, they collaborate with other people to get reasonable accommodations at work. So we do talk to people about what is reasonable at work and what changes can be made to help you keep you there as long as possible. We help empower clients to seek out and obtain their own resources and to keep participating in life. And we teach you how to do that, advocate for yourself. And then some OTs might do other advocacy things out in the community, like serving on a policy board to help with housing accommodations in the community. That's just an example. There's tons of things, but advocating is basically meaning standing up for yourself and your needs. Okay, we might do group therapy. So groups are where you get a bunch of people together and you're working on one particular thing. The therapists here do an exercise group, and that's working on balance and movement and helping people maintain their strength in the community. So that's one example of those. Some other groups out there might be mental health groups and that work on social connections and how to make appropriate social behaviors in the community. You might have a group on driving safety. Driving safety is something that's huge and everybody wants to know about. So driving is something I think would be a great group thing that an OT could do. So outcomes. So we talked about evaluation. That's when we look at you, we decide what you need to accomplish to be able to participate in your activities. And then we talked about treatment. I gave you a lot of examples of treatments that we might do and what kinds of things we work on. So now then we come to the outcomes. So outcomes can be measurable, or they might be an experience by our patient. So measurable, an example would be improved range of motion. So maybe you could reach here, but now maybe you can reach here. So that would be a measurable difference for us to see. You might have an improved score on a 9-hole peg test. Some of you might know what a 9-hole peg test is. You're basically picking up all these little pieces and putting them in there as quickly as you can and then taking them back out. It's a measure of coordination, of fine motor coordination and dexterity for us. It gives us a number so that we can see an improvement or a decline. So now, taking that, it's how is the client's experience though? What is the outcome for the client? Because the client usually doesn't care about the numbers, but they care about what they can do, right? So you might have increased range of motion, but as a client, now maybe that makes it easier for you to wash your hair because you can reach up higher. With the peg test, so you might have a quicker score on the peg test, but that might translate to maybe you can pick up small objects that you used to not be able to pick up, whether that be game pieces because you want to play games with your grandchild, or picking up coins because you're a coin collector. I don't know, whatever somebody might be interested in picking up. So let's talk about OT at the LouRuvo Center. So at the LouRuvo Center for Brain Health, we see a large population of people with brain dysfunction. So mainly progressive disorders. So brain health, in the brain health clinic, we see people with Alzheimer's, people with frontotemporal dementia, and people with mild cognitive impairment. And there are more, but I'm mainly just listing the things that I mainly work with here. We might see people with multiple sclerosis or transverse myelitis. And we might work with people with movement disorders, so Parkinson's, Huntington's disease, atypical forms of Parkinsonism, so that's the other things like PSP, MSA, all those different things that you still have movement disorders, but maybe not quite Parkinson's. So those are some diagnoses we might treat here. So what do we do with those people in particular? So with Alzheimer's disease, as far as ADLs and IADLs go, which are those abbreviations I talked about earlier, activities of daily living and instrumental activities of daily living, we might help the caregivers set up a limited amount of clothing options, so that way the person maybe that's overwhelmed by their clothing choices because they're cognitively impaired, they can remain as independent as possible choosing their clothing options. So we might work with the family on how to make it less overwhelming for the person. We might work on sequencing of brushing your teeth. Some people will kind of get out of sequence because of their cognition. They might forget what steps come first and then what comes next, so we work with them on how to sequence that or how to make that possible at home. We might do a driving safety evaluation with somebody who's just starting to have memory impairments to see if they are still safe to drive or if maybe it's time to turn in the keys. Okay? We might develop an exercise program so that it's safe and easy to follow because we don't want anyone to get hurt, but exercise is super important. It doesn't really matter what level of cognitive impairment you have. You definitely need to be exercising, and that's when PT really come into play too. They're really good at adapting programs for people. We might work on them with compensatory memory techniques and strategies because remediation, like fixing cognitive impairment, isn't quite always the goal because sometimes it's just not going to happen. But what we can do, like I said earlier, is work with people on how to manage their cognitive impairments. They might use planners or lists or getting into a routine, a normal routine that becomes familiar to them. We might work on somebody with home safety modifications to make them safer at home. Some examples of changing the home around are maybe putting a lock in a certain area to prevent wandering out at nighttime. because you don't want your loved one wandering out at night. That could be dangerous in a lot of ways. We might talk to you about colors and how colors can help draw attention to or distract attention away from particular rooms in the house that you don't necessarily want somebody going to, or you do want somebody to find, like the bathroom. We might do caregiver and patient training, so we might train people on communication, because communication can be very tough when you start having cognitive impairments. How the family communicates with the person makes a big difference. So we might teach them communication strategies. We might teach them coping and how to manage problematic behaviors that might come up. And then we want to get them into an established routine. We want to teach them how to get enough leisure activity, get enough exercise, make sure they're eating properly and sleeping right, and make sure they're getting social interaction. And that's so important. Those are all the important parts that contribute to the brain. And it helps fulfill that person's need to live a productive life and to focus on their positive aspects and the things that are still really good, because everyone's got strengths no matter what's going on in your life. So we focus on the strengths and help figure out what they can do in the home. With MS, so with multiple sclerosis, for ADL and IADL training, we might work on cooking, we might work on homemaking tasks, we might use some of these utensils to help people be able to feed themselves better. I'm good, right? So we have lots of different stuff, and a couple of these are just some examples that I have, but there's a lot more out there. But we might use some kind of a suction cup bowl or something so that it's not moving around if you only have use of one hand. We might use some built-up utensils. They have a much bigger handle. They're easier to hold on to. They're not easy to drop. We might use a weighted cup for somebody who has tremors. Weighted stuff really helps with tremors. It kind of gives you a little bit more control so you're not spilling. We might use a plate guard. A plate guard is a thing that slips right onto your plate, and it helps you be able to scoop food onto your spoon or your fork without using your other hand if you only have use of one hand. We might use a rocker knife. A rocker knife has an edge kind of like a boat, the bottom of a boat. So when you are cutting, you don't have to saw back and forth like this. You can just push down on your food, rock it a few times. It's a one-handed cutting technique. So you don't need to hold your food with a fork and slice back and forth. You can just cut it with one hand. For people who don't have any fine motor use of their hands, we have adaptive tools that just fit onto the hand, and you don't have to use your fingers. So this is an example of a button hook and a zipper pull. So we can teach somebody how to button their blouse using their hand, or to zip up using something like this. And we have stretchy shoelaces. They're good for if you want to wear shoes that need shoelaces. They stretch when you put your foot in them. That way you don't have to tie and untie them. So, because a lot of people can't reach down and tie their shoes. We also use a lot of different writing utensils. So there's a lot of different things you can write with, like built-up weighted utensils for writing, different things like that. So we might work on them with fatigue management, teaching somebody energy conservation techniques and body mechanics so that they may remain at work, or so maybe that they can do an exercise program prescribed to them by the physical therapist, but maybe up until that point they hadn't have enough energy because they're using all their energy just to cook a meal, or all their energy just to take a shower and get dressed. So we teach them how to manage that energy a little bit better. We might work on them with developing a stretching and exercise program. Stretching is especially important for people who might have contractures or spasticity from the MS affecting the brain. You want to be able to stretch and do that properly so that it doesn't get worse. We might work on somebody with home work or driving modifications. So for home, we might use some different body mechanics of how to do things. We might teach somebody adaptive equipment that they can use at home to improve their ability. We might make recommendations for driving equipment to make driving a little bit safer. They make all kinds of different things to make you safer in your vehicle as far as physical limitations go. So maybe that's a wider rear view mirror, or it might be, a seatbelt puller because you can't put your seatbelt on because you can't reach it. We might recommend durable medical equipment for home, like a shower chair or handrails for getting in and out of the shower, or a proper, toilet seat height. We might do some cognitive rehabilitation. So for cognitive rehabilitation, we focus a lot on compensatory strategies to help the good parts of your cognition. So some common complaints that people have, if you're misplacing things and you're missing appointments, that might be something wrong with your memory. If you are having trouble concentrating and can't do two things at one time, that might be a problem with your attention. If you are unable to plan or carry out an activity or decide what step comes first in an activity, that might be a problem with prioritizing and organizing. If you are having difficulty managing your money or managing your medications, then you might have something wrong with your ability to problem solve. So we look at that and how you're doing at home, and we teach you compensatory methods on how to manage those deficits. We might work on stress management. Stress management is really important. So relaxation and deep breathing techniques, teaching people how to be better organized so that way they are able to be less stressed. They know where something is. They're not forgetting something all the time. So those are some things we might do. And again, establishing a routine, because a routine is important for everybody. Our bodies and our minds really like to be in a routine. If we're doing things different every day, we're more likely to forget something because it's just not something that we're used to. And then Parkinson's disease. So with Parkinson's disease population, in ADLs and IADLs, we might work a lot on teaching them daily hygiene strategies. We might teach them how to independently dress themselves using either equipment or a different technique. We might teach somebody to feed themselves with an adaptive utensil, whether that's weighted to reduce tremors, or there are lots of different ones out there. Some of them vibrate a little bit to help kind of stabilize the spoon bowl. We might help people get on a regular schedule for toileting. If you're having a lot of accidents or you just can't quite make it, maybe you need to be on a regular schedule to manage that better. And we might work on car and bed transfers and shower transfers and toilet transfers, all those things that tend to be really difficult for people who are having trouble with freezing and stuff. Caregiver training. So caregivers, we teach them body mechanics. So a lot of times caregivers might have to help lift the feet into the bed, or they might have to give you a little boost, or they might need to be right next to you to make sure you don't fall. So we teach them body mechanics so they can protect their backs and their legs, and they can stay healthy and keep all of their joints nice. We might teach them how to assist with your home exercise program. Some people might need an extra person around to help them do their home exercise program. Not everyone can do it independently, so we might teach the caregiver how to help them do that. We might work on them with home safety. So again, the durable medical equipment recommendations like a shower chair or grab bar placement, or maybe changing the layout of the home to make it a little bit safer. We also might talk about fall hazards with somebody. What makes people fall? What are some things you could change around in your house? Maybe like removing throw rugs or improving the lighting in an area that someone tends to get caught up in. We might work on different exercise techniques. So some of the exercise that the therapists here work on are the large amplitude movements. Like a lot of the therapists here are, some of them are BIG certified. I don't know if you guys have heard of Big and Loud, but it's a program to help patients with Parkinson's or other similar disorders move bigger and move with larger movements to help them be able to maybe get dressed or walk a little safer. And then there's also PWR, it's Parkinson Wellness and Recovery, and I get to do that next weekend, so that's exciting. And Trevor's coming too. So we'll be learning those techniques and how to use that for patients with Parkinson's. And then integration of self-management and cognitive behavioral strategies. What that basically means is teaching them how to use the good aspects of the cognition, or maybe make some changes around the home to keep somebody as independent as they can for as long as they can. Maybe schedules, maybe routines, lots of different. It's hard to give examples because there's a bazillion examples, but that's the basics of it. These are some of the highlights of the OT program that we have here. So we have a driving simulator. What we are using the driving simulator for is evaluating and making recommendations for safety. Maybe you're wondering, is my loved one safe to drive? So I'm not here to be like, yes, you can drive, or no, you can't. But what I do look at is what is very concerning to me. And maybe it's time to go to the DMV and take a driver safety evaluation. Or maybe you're doing okay right now, but maybe in 3 to 6 months you might want to get rechecked. So it's just looking at how safe you are, how able you are to pay attention to hazards, how your reaction time is, different things like that. We have a cognitive rehabilitation focus here, and we focus on using compensatory strategies to make you as independent as possible. And I talked about some of those. We talk about using planners, how to manage your time, how to manage your finances, how to manage your medications, whatever it is that you need to work on. And then we have a multidisciplinary collaborative team approach, which I really like about working here. Everyone here really works well together, we communicate well together, and we really focus on the person as a whole. So we might sometimes make referrals to other professionals. Maybe we might refer to another OT. Maybe it's something occupational therapy, as you notice, is really broad. And so sometimes we kind of focus our efforts in one particular area so that we can be better able to treat people. So maybe I might make a recommendation to another occupational therapist who is better suited to treat something. Or I might make a recommendation to another occupational therapist setting that might be more appropriate for somebody. Sometimes when I see people, maybe they might need home health. They might need somebody to come into their home and see how they're functioning in their home. Or maybe somebody might need to go to inpatient rehabilitation. They might need to get some intense, quick therapy to get them back up and going. I might make a referral to physical therapy, although mostly right now they just make referrals to me because they have everyone already. The physical therapists here are so busy, but I might refer to them if they aren't seeing somebody already. If I notice somebody's having a balance problem, or they're falling all the time, or I did some scores with them and they're just not quite where I'd like them to be. I might make a recommendation to speech therapy. Speech therapy can work on people who are having swallowing issues, and also cognition they work on. I might make a recommendation to a social worker or a care coordinator if I feel like you are struggling with what resources you have, you need some help but you don't know where to go. Psychologists, physicians, if I notice you're having a decline, I might refer you back to your doctor just to get a checkup and make sure everything's okay. Make sure that something's not blocking you from making progress. And then maybe a medical equipment supplier. So a medical equipment supplier might provide you with a wheelchair or a walker, or help you get the right shower chair for your home, or they might know where you can get your grab bars installed, who can install your grab bars for you. And then here's some reasons for OT referral. So you now know what we do and how we do it. So why might you come to see somebody like me or somebody else, another OT? So if you're having difficulty caring for yourself, if you're having difficulty with working or participating in leisure activities that are important to you and you need to be able to do those. If you're having difficulty with functional mobility or transfers, especially like getting in and out of the shower or the tub. If you have a new onset of cognitive difficulties, a new onset of weakness, so you just suddenly got weaker and maybe you're falling more. You might have impaired coordination. Maybe you're not able to pick up things you were used to pick up. If you need a driving evaluation, we are starting that driving program up Currently, it will eventually be started up completely, and it will be out-of-pocket pay because Medicare doesn't cover driver safety evaluations currently. But I do assess driving ability during an evaluation, and I talk about driving with a person during a typical evaluation anyway. And then anyone with a newly diagnosed neurological condition, the earlier we can help somebody, usually it has a better outcome, because we can prepare people for what might come and what things you might want to look for in the future. So let's wrap up. Can anybody tell me like a brief summary of what OT is? Anyone? I don't have prizes or treats. Yes?
Just helping someone through their activities of daily living, just normal things that we take for granted.
Great. She said that OT is helping people through their normal activities of living and things that we all take for granted. Sometimes we might start having trouble with those. That's great. When would you maybe need an OT? Just one reason. What's a reason maybe you might need OT? I just want to make sure you guys learned something today. Balance, okay? Yeah, you might be having balance issues. You might be falling more. Maybe you can't get in and out of the shower safely. And it says who are OT practitioners, but basically that's kind of a poorly worded question. I was just trying to be smooth and do the what, why, who, how. But anyways, we talked about who OT practitioners are. Where can I get OT? So can somebody tell me a different setting? Yeah, you can get it here, he said. What's another setting you might find an occupational therapist?
Physician referral.
Yeah, a physician referral. And that's kind of the last question is how do you receive OT services? And that we did not cover, but if you feel you're in need of OT services, then it's something to talk to you about with your physician and they can make an appropriate referral for you. Okay? So questions. I did save some time for questions. Yeah. Okay, here? Anywhere? She wants to know what kind of insurance you have to have occupational therapy. It really depends on the setting. So depending on what your insurance is, it's just like when you go to the doctor. You need to discuss that with them prior to your appointment. So, you know, just like if you're going to the doctor, you can't just walk in and say, I want to be treated. You have to make sure they take your insurance. So it's the same thing. But almost, you know, occupational therapy is covered by all major forms of insurance. It just depends on the setting. You know, some take Medicare, some take Sierra Health, some take, you know, all the different ones that are out there. Blue Cross Blue Shield. But you have to check with your setting before you go to that particular setting. Yes?
If someone is, you know, they can do all their ADLs okay, but there's a driving issue. Can they, through a doctor, because sometimes the doctors don't want to submit a form to DMV, which to me is just baffling.
Yeah, because it is.
Come in with a referral from the doctor and go through the driver's simulator here, and then, I mean, or do they have to go through the whole program?
So the driver simulator alone, eventually, once we have that completely up and running, which should be very shortly, it's going to be pay out of pocket. I mean, I have it, but we're trying to get everything, all the kinks worked out. But it's going to be pay out of pocket. And that one, yeah, you'll just have the doctor refer you, and you come in, and I will do a driver safety evaluation with you. If it's a big concern and you want to get it addressed sooner, what you can do is you can ask for a referral to OT for just an evaluation. And when you come to see me, I'll look at how you are doing and I'll ask you all those important vital questions to figure out if maybe it's okay to be driving or not. Because there are a lot of tests and different things I can look at besides just using the simulator to kind of gauge where somebody is. The question was about driver rehabilitation. Sorry.
How good are the trial studies that they advertise a lot on TV, you know, trials for different diseases? How good are those? Are those also under Cleveland Clinic? Are there trial studies going on?
Trials for what in particular?
Like Alzheimer's, Parkinson's, and all that kind of stuff.
For medications though? Medication trials?
Well,
or?
they're not, I don't think they're always medications, but they get you in the trial and see what your status is. I wonder how good that evaluation is taken.
I'm not super familiar with, I think it's going to depend on, she's asking about are the trials that are out there these days for patients with neurological disorders, are they good? Or what are they looking at? What are they covering? It's really going to depend on what trial you're enrolling in. They're all very different. And what trials are mainly doing is helping gather our information base and improving our knowledge at things so that we can make new medications or come up with new treatments and stuff. So they're really not for treatment purposes. They're really to see how things are working and to make sure we're moving in the right direction. So a trial is more, I'm not super familiar or involved with a lot of trials, but we do have a trial program here. Maybe they might be able to answer your questions for you. Oh. You have a flyer for that? Great. She's got a flyer for that, so that might be good. Any other questions? Okay. All right. Wow, you guys are a quiet group, but I hope you learned something today. I hope that you got a better understanding that we don't just look at jobs and we don't get people jobs. So, all right. Anything else, Susan? Thank you.